Fortunately, Professor Ihab Rida, he came to save the situation. So I thank Professor Ihab Rida for his support. Professor Muhammad Rida, professor from University of Alexandria, and he will present to us 3 different topics. First topic will be MR spectroscopy as a problem-solving tool. The second topic will be in dynamic MR CSF flow sequence. And we hope, if we have enough time, to see the third topic as clinical application of brain MRI tractography. Please welcome with me and for Professor Ihab Rida. Thank you, Professor.
Thank you, Mr. Chairman. بسم الله الرحمن الرحيم والصلاة والسلام على خاتم المرسلين. First, I would like to thank the organizing committee and Professor Muslih al-Maddadi for his kind invitation. We will try to present the experience of Alexandria School of Radiology in the domain of the advanced neuroradiology package. In fact, we started to use this package since about 4 years. Globally, MR spectroscopy is used as a method to evaluate the metabolites in the body in vivo. We have to answer some questions. The first question, is the lesion neoplastic or not? I mean that to differentiate tumors from encephalitis, post-irradiation necrosis, TDL, granulomas. If we know, or if we diagnose it as a tumor, if this is a tumor, we have to answer whether this is a primary tumor or a secondary one. If it is a primary, we have to answer, is it a high-grade or low-grade tumor? Finally, spectroscopy also has its role in epilepsy, Alzheimer, and other diseases. Just a very rapid review about the normal and abnormal spectral pattern. This is the normal spectral pattern. We have to focus on the NAA and the choline ratios. When the curve is ascending like this, it is a normal one. If the N-acetyl aspartate is low, it is a descending curve, and this is an abnormal one. We usually use ratios between these different components. I'll just present a very broad guidelines how to use these ratios. Usually, when the choline is raised, this denotes bad things, denotes cellular, the wall of the cells is multiplying, denoting tumorous effect. So whenever the choline is high, it goes towards neoplastic. Choline creatine less than 1 is non-neoplastic, more than 1.5 neoplastic, near 2 it is high grade. On the contrary, when the N-acetyl aspartate is low, it is non-neoplastic, and when the 0.6 is high, it is non-neoplastic, less than 0.6, it is neoplastic. Myoinositol, when it is high, denotes low grade. We will see this in the different cases. The last ratio, choline creatine and choline NAA, to differentiate between radiation necrosis and tumor recurrence. If less than 1.8, it will be radiation necrosis. More than 1.8, it will be tumor recurrence. Now, let us apply these guidelines on these different cases. A male, 21 years old, coming for fits. In fact, on the flare, we have a precentral gyrus lesion, hyper-intense on flare, iso-intense on T2, slightly hypo-intense on T1, no contrast enhancement, thin tail in the flare, no blooming. So what do you suggest? Is it a low-grade tumor? Do we have to proceed to biopsy in a pre-central gyrus lesion? I think it's better that we go to spectroscopy. By spectroscopy, discover that the spectrum is totally normal. It is non-neoplastic. In fact, this was the case of cortical dysplasia, tail or cortical dysplasia, where the cortex is thickened, and this is the characteristic hyper-intense tail going toward the ventricle. And the patient was saved from biopsy. Second patient, a male, 75 years old, coming with headache. On T2, on FLAIR, we can see that the whole left temporal lobe is tumefied. A small-like lesion along the anterior part of the temporal lobe. Hypointense on T1 with mass effect effacing the cortical sulci. After contrast administration, at the anterior part of the temporal pole, there is an enhancing mass-like. No blooming, and there is diffusion restriction. So what are the suggestions? We're thinking between glioma and encephalitis. Proceeding to biopsy or to spectroscopy. By spectroscopy, we discover that the NAA choline ratio is 1.3, and this is a non-neoplastic pattern. Performing perfusion also, it is hypoperfused, and this is R in favor of herpetic encephalitis, not glioma, and the patient was saved from biopsy and improved on medical treatment. Another patient, female, 51 years old, coming with subacute left hemiparesis. There is right parieto-occipital, cortical, subcortical hyperintensity on FLAIR on T2, hypointense on T1, slight hyperintensity denoting blood products, blooming seen, after contrast administration, irregular enhancement. With diffusion, some areas are restricted and other areas are not restricted. So what do you think? Is it a tumor or it is a hemorrhagic infarction? Again, performing spectroscopy, the ratio is preserved, and this is a non-neoplastic process, and again with the presence of lactate, this is a hemorrhagic infarction, a typical form. And if we go retrogradely, we can see that the internal carotid on the right side lost its normal signal void pattern, confirming again the atypical hemorrhagic infarction. Another patient, 61 years old, coming with headache, confusion since 3 months. On the FLAIR and on the T2, we can see that there is asymmetric bilateral temporal lobe involvement, asymmetric inferior frontal gyrus involvement, asymmetric basal ganglia and thalami involvement, hyperintense, isointense on T1 with mass effect, swollen left temporal lobe, no definite restriction, no blooming, no contrast enhancement, isoperfused on perfusion. So what do you think? Is it a tumor or it is encephalitis? Again, do we proceed to biopsy? Just resort to the simple maneuver. Here we can see that the NAA is low, NAA choline ratio will be less than 0.5, and with using TE, the myoinositol is very high, and again, these are the criteria for gliomatosis cerebri, and it wasn't encephalitis, and proven by biopsy to be gliomatosis. Another patient, male, 33 years old, headache and confusion. You can see that there is nodular lesion along the right parieto-occipital, high, cortical, subcortical, surrounding edema, hypo-intense rim on flare on T2, hyper-intense rim on T1, following contrast administration, irregular thin rim enhancing, central diffusion restriction. So perhaps it is an abscess. With SW, there are blood products. So is it an abscess or is it a glioblastoma? Again, proceed to spectroscopy. Again, the ratios are preserved and presence of amino acids, succinate, are in favor of abscess. The patient didn't improve on antibiotics and he was operated and the abscess was drained. This is one of the most beautiful flowers simulating an water bubble. Another case, male, 44 years old, coming with subacute left hemiparesis. There is a cystic lesion on the right frontal lobe, irregular margin, CSF-like central portion, mild perifocal edema grade 1, following contrast administration, peripheral thin enhancement, no restriction, no blooming. So, what do you think? Is it a complicated inflammatory cyst or a neoplasm? Again, proceed to spectroscopy. The ratios are altered. The NAA is low in comparison to choline. This is a neoplastic pattern. On perfusion, we can see hyper-intense or hyper-perfused rim denoting neoangiogenesis, and the diagnosis of tumor was settled. The question is it a single deposit or a primary tumor? We have to interrogate the area all around the tumor, and all around the tumor, the NAA was preserved, denoting normal, non-infiltrating parenchyma around the tumor. And this is in favor of a deposit. And patient proved later on to be harboring cancer lung. This is the most beautiful cave in Nevada, United States. Another patient, male, 30 years old, complaining of non-Hodgkin lymphoma under treatment, now complaining for decreased vision. And we noticed this lesion along the left side of the splenium of the corpus callosum, along the periventricular peritrigonal area, hyper-intense, slightly hypo-intense on T1, exerting minimal mass effect, indenting the outer border of the ventricle. Not restricted on diffusion, no blooming. Again, the differential diagnosis. Is this lymphoma or a demyelination? Do we have to proceed to another type of chemotherapy or just give corticosteroids? Proceed to spectroscopy. The curve is a normal one. The lesion is isoperfused, and the diagnosis was demyelinating lesion, not lymphoma, in spite that the patient was treated for lymphoma. This is the most beautiful child in 12. Another patient, male, 70 years old, also under treatment for lymphoma and coming for a recent headache. And we see that there is an extraaxial mass, high, right posterior parietal, slightly hyper-intense on flare, hypo-intense on T1, hypo-intense on T2, exhibiting contrast enhancement with a dural tail, and exhibiting diffusion restriction. Again, the differential diagnosis. Would it be a lymphomatous infiltration or an accidental meningioma? Here, by spectroscopy, the choline is very high. Still, there is NAA. These are not the criteria for meningioma. By perfusion, the lesion is hypoperfused. Again, these are not criteria for meningioma. And the diagnosis reached was lymphomatous infiltration. another patient, 56 years old, was operated before for glioblastoma and treated by radiotherapy. 2 years later, is coming for epilepsy. And along the bed of the operated tumor, we can see that there are heterogeneous area with mass effect, hypointense on T1, and exhibiting different patterns of enhancement following contrast administration. An area of Swiss cheese appearance, cystic area, blooming, and there is a pinching of the trigone on the right side without any enhancement here. Again, is this radionecrosis or recurrence? By spectroscopy along the lateral area, along this lateral area, the NAA and choline ratios are preserved, going towards radionecrosis, while on the medial portion around the ventricle, the NAA is very low, denoting that this is recurrence. And the diagnosis was that there is a non-enhancing peritrigonal area of recurrence, while the lateral part was a post-irradiation necrosis. In epilepsy, this is a male, 7 years old, coming with fits. Which side is abnormal? We can see this is axial, T2. You can see there are symmetric. On coronal thin cuts, both hypocampi are symmetric. On the flare, coronal oblique thin cuts, both are symmetric. And on the 3D T1 gradient, both are more or less symmetric. Again, which side is the abnormal one? Just proceed to spectroscopy, and we use this ratio, which is the NAA over choline plus creatine. Normally, it should be more than 0.65. It is abnormal on the left side, while on the right side, it is 0.89. So there are metabolite alterations on the left side, which corresponded to the EEG results. However, things are not always straight, and we are confronted with situations that are little bit not direct. And I have to mention always, never to rely on spectroscopy without conventional data. And you will see that example. This is the case, and this is a typical pattern waveform of neoplasm with low depleted NAA, very high choline. But if we are regarding to the conventional sequence, these are multiflocculent, coalescent, T2 hyperintense nodule along the gray-white matter junction, sparing the callosoceptal interface, minimal enhancement, no restriction. In fact, this was Adam and not neoplasm. So if we just have some messages, some take-home messages, we have to say that believe in the conventional data. Please believe in them, but choose with the spectroscopy. I mean that we have to prepare a list of differential diagnosis from the conventional sequence, and then to choose from this list by spectroscopy, not the reverse. Spectroscopy should be performed with diffusion and perfusion to increase the accuracy. Lastly, when there are hemorrhage or when we are near the bone, this will degrade the image quality. And sometimes we refuse to perform the examination. I thank you very much. Our second topic will be dynamic MRI CSF flow sequence as a problem-solving tool. What are the indications to perform this special sequence? Whenever you have a case of ventriculomegaly, whether it is hydrocephalus or atrophy, perhaps you will need this sequence. In cases where there is clinical suspicion of normal pressure hydrocephalus, cases of idiopathic intracranial hypertension, cases to assess post-operative 3D third ventriculostomy performed by endoscopy, and lastly, in cases of Chiari malformation. What is the technique? The technique is very simple. We are performing a phase contrast sequence. This phase contrast sequence will demonstrate the movement of the CSF in the basal cistern and the aqueduct. Normally, we should see flow in the aqueduct, we should see flow in the fourth ventricle, we should see flow from the fourth ventricle to subarachnoid space, as well as in the prespontine cistern, no flow in the suprasellar area. This phase contrast sequence is coupled with this thin sagittal 3D cis sequence. This sequence is a heavy T2 with a 0.5 millimeter sequence. The first case is a female, 6 years old, 67 years old, coming with the clinical suspicion of normal pressure hydrocephalus. You can see that the ventricles are dilated a little bit, more than the cortical sulci, signal void on the aqueduct, and the aqueduct is more or less patent. In the phase contrast sequence, it is totally normal as regarding the patency, but when we perform calculations, there is a hyperdynamic CSF flow through the aqueduct. Normal flow will be up to 6. Here it is 8. The stroke volume normally up to 20. Here it is 91 microliter. And this denotes that it is a normal pressure hydrocephalus. Not only that, but it denotes that it is good shunt responder. If it is less than 42 microliter, it will be a bad shunt responder. Another case, same age, same category, same complaint, female, 64 years old, coming for a normal pressure hydrocephalus. Again, ventricles dilated, no transependymal CSF permeation, cortical sulci are not dilated, and few ischemic foci. Is this a normal pressure hydrocephalus? The mammato-pontine distance is 10 millimeter. So is it atrophy or normal pressure hydrocephalus? Performing this marvelous sequence, we can see that there is a web, undiagnosed, neglected, unnoticed web since 60 years. This web is obstructing the aqueduct and not really noticed on the sagittal T1. Performing the phase contrast sequence, we can see that the aqueduct is obstructed, no flow passing to the fourth ventricle from above, but there is an abnormal flow in the floor of the third ventricle. This is the abnormal flow, and this is the obstructed aqueduct. So, this is an old aqueductal stenosis which is compensated by spontaneous third ventriculostomy. And this is the reason why there are no transependymal CSF permeation around the ventricles. The obstructive hydrocephalus is compensated by this spontaneous shunt. Another case, male 17-year-olds coming for paraparesis. Again, ventricles dilated, no transependymal CSF permeation. The fourth ventricle is non-impressive. Perhaps there is an element of aqueductal stenosis. Actually, yes, the aqueductal is stenosed, but still no transependymal CSF permeation. It is near totally occluded. The mammato-pontine distance is very narrow. It's 3 millimeter only. proceeding to the phase contrast, again occluded, but there is a large spontaneous third ventriculostomy. Again, this spontaneous third ventriculostomy compensates for the obstructive hydrocephalus in this young adult. Another patient, female, 17 years old, coming with clinical suspicious of idiopathic intracranial hypertension. Again, we can see nicely demonstrate the hydropes around the optic nerves bilaterally. The ventricles are non-impressive, cortical sulci are non-impressive. Here the aqueduct is open. There is an empty cella performing the phase contrast. You can see that the aqueduct is working, patent, and the flow is going to the subarachnoid space. It is a normal CSF flow pattern. So a normal MRV also. So this pattern with hydropes in the optic nerves, normal patency of the aqueduct, normal MRV, again the diagnosis of idiopathic intracranial hypertension was settled. Another patient, female, decreased vision, coming also for idiopathic intracranial hypertension. Again, there is optic hydropes, non-impressive ventricular system which is slightly dilated, empty cella, normal MRV. Again, is it idiopathic intracranial hypertension? Look, with this marvelous sequence again, we can notice a very thin web along the distal part of the aqueduct, and again, no flow from the aqueduct to the fourth ventricle, and the small spontaneous third ventriculostomy. And the diagnosis was an aqueductal stenosis compensated by spontaneous third ventriculostomy and not idiopathic intracranial hypertension. A case of tectal tumor, and this tectal tumor was treated by endoscopic third ventriculostomy. After this endoscopic third ventriculostomy, the dilated ventricles will not decrease in size. It is just the pressure which diminish. So the surgeons want to know, is this a functioning shunt, yes or no? Again, we can see here the small defect of the endoscopic third ventriculostomy. Performing the phase contrast, we can see the functioning shunt. This is a shunt, the shunt, and this is the gap. And again, we can answer the surgeon that this is an adequate functioning third ventriculostomy. Another patient, child, 1 year old, complaining of nystagmus, delayed talking. We can see that there are supra and infratentorial ventricular dilatation and no transependymal CSF permeation. The fourth ventricle is dilated, and we can see that there is a midline posterior fossa cyst seeming to be continuous with the fourth ventricle. The aqueduct is patent. Performing phase contrast, we notice that the aqueduct is patent, the fourth ventricle is patent, but no communication at all between the fourth ventricle and the subarachnoid space in the posterior fossa. No communication with the subarachnoid space, showing no flow at all. So the diagnosis of a no midline communication between fourth ventricle and posterior subarachnoid space, the diagnosis of persistent Black's pouch cyst was settled. Another patient, female patient, 50 years old, coming with headache. Both supratentorial and infratentorial ventricular dilatation seen. Again, no transependymal CSF permeation. We can see that the aqueduct is patent. On the conventional sequences, the fourth ventricle seems to be normal, but on this spatial sequence, we can see there is a web obstructing the fourth ventricle. This was confirmed on the phase contrast, where there is no connection at all between the fourth ventricle and the subarachnoid space, and confirming fourth ventricular outlet obstruction. Another patient, male, 47 years old, coming for headache and space-occupying lesion. This was an interesting case. The surgeon was suspecting a tumor. In fact, on the conventional sequence, there were ventricular dilatation, again, without any transependymal CSF permeation. On thin cuts, we see this very small web and decreased mamellopontine distance. On phase contrast, what do we see? The aqueduct is totally stenosed, and again there is a large pumping shunt, spontaneous third ventriculostom. So this is an aqueductal stenosis compensated by a large shunt. But still, why the patient complaining? Why the patient is still having headache? Look, here is the answer. Still, the fourth ventricle is in place with the cerebellar tonsils low-lying. This is a case of Chiari-1 malformation. And the reason of the headache will be a flow compromise along the foramen magnum. The foramen magnum, along its anterior subarachnoid space, is compressed due to the cerebellar tonsils. And we can see this flow alteration and this aliasing denoting compromised flow at the foramen magnum secondary to Chiari-1 malformation as the real cause of its headache, while the aqueductal stenosis, which was neglected since a long time, is totally compensated by the spontaneous third ventriculostomy. Another case, male, 13 years old, with a long history of amnesia. Supratentorial ventricular dilatation with no transependymal CSF permeation, and a cystic-like lesion in the midline, splaying apart both cerebral peduncles. The question is this cyst intraventricular or cisternal? Proceed to the sequence. This thin sequence, we can see this is the cyst, and this is the third ventricle. So this cyst is purely cisternal. It is not intraventricular. The question is it communicating with the cisterns, yes or no? Does it need an operative interference, yes or no? We can see here that it is not communicated at all with the basal cisterns. Patient has been operated and improved. Our last case, patient coming with a skull-based defect and a meningocele. We can see here that there is a defect along the right petrocleval fissure and a meningeal sac protruding down in the parapharyngeal space, and the surgeon wants to know if there is direct communication between the CSF flow in the skull with that space. The answer was yes, it was communicating. I thank you very much. The third topic, and the last one, I'll promise, is the clinical application of brain MRI tractography. In fact, tractography relies upon diffusion sequences. But we have to know thoroughly the different white matter tracts. The white matter tracts in the brain are divided into three main categories. The first one are the projection fibers, second one are the association fibers, and the third, the commissural fiber. The commissural fibers joins both hemispheres, which is the corpus callosum. The projection fibers are from one side, the higher areas, the cortex, to thalamus, to brainstem, to spinal cord. These are the corticospinal tract, thalamic radiation, corticobulbar tracts. The most complicated one are the association fibers, which connect different lobes in the same hemisphere. We will see this. These are the projection fibers. This is the cortex, and then thalamus, second station brainstem, third station spinal cord. From the cortex to the thalamus are the thalamic radiation. From the cortex to the brainstem is the corticobulbar tracts along the mid part of the internal capsule. From the cortex to the spine are the corticospinal tracts along the posterior part of the internal capsule. The notion of these anatomical landmarks are crucial. In the association fibers, it's more complicated. We have here frontal, parietal, occipital, temporal lobes. Association fibers are called fasciculi. So if the white matter tract connects the whole four, this is called superior longitudinal fasciculus. Now, there is an inferior one between the occipital and temporal lobe. And we have a fronto-occipital, superior one, inferior one. And lastly, an uncinate fasciculus. To summarize, the one who connects all of them is the superior longitudinal. The one who connects the occipital to the temporal is the inferior longitudinal. Frontal to temporal is the uncinate, and then to fronto-occipital. Let us pass to the clinical applications of these tracts. This is the patient coming with a mass along the left precentral gyrus. And the surgeon wants to know whether the tracts are displaced anterior to the mass or posterior to the mass. The corticospinal tracts are here or here. Why he's asking this question? Because if the tracts are anterior, he can attack the mass from posterior aspect. If the tracts are displaced posteriorly, he can attack the mass from anterior. The first thing is to perform a 3D gradient thin cuts and to perform reconstruction to see the lesion. Here is the lesion on the coronal, the lesion on the sagittal, the lesion on the axial. And this was our first case. And we can see here the mass posteriorly displacing the corticospinal tract. They are still intact, but displaced posteriorly, as we can see here. On the coronal cuts, this is the mass, and we can see that the superior part of the corticospinal tracts are deviated medially in relation to that mass. On the axial series, here is the mass. When we are using the advanced package, we are seeing from above, while here we are seeing from below. This is why the left side is here on the imaging, and the left side is on that side on tractography. And we can see that the mass is here, the tract are deviated posteriorly and medially. Another patient with a road traffic accident, multiple epidural collections, and we have a right occipital intraaxial hematoma. The surgeons want to know, to evacuate this hematoma, but wants to know where is the optic radiation. What is the relation of that hematoma to the optic radiation? This is what the answer. This is the normal left optic radiation. while the optic radiation on the affected part is attenuated and displaced inferiorly, denoting that the hematoma is above that optic radiation. Another patient coming with hemorrhage along the pons, the pontine area, as well. Here we can see the blooming, as well old hemorrhage along the lentiform nucleus and posterior part of internal capsule, producing also blooming. On tractography, we can see that there is total amputation of the corticospinal tract on the pons and thinning of the corticospinal tract higher up, secondary to Valerian degeneration. Another patient coming with a mass along the physiform and lingual gyri, enhancing mass with a low ADC, denoting that it is an aggressive tumor. The surgeon wants to know where is the optic radiation in relation to that mass. Here is the answer. Again, this is the mass. The optic radiation is along the outer margin of the mass and stops short before reaching the cortex because it has been infiltrated. If we compare it with the contralateral one, we can see that the optic radiation reached the cortex here while stopped short due to being infiltrated by the tumor. Patient with cavernoma along the right cerebral peduncle. This cavernoma must be treated surgically, and the surgeon wants to know where is the corticospinal tract. Is the corticospinal tract shifted anteriorly in relation? Is the corticospinal tract shifted anteriorly or posteriorly in relation to that cavernoma? Here is the tractography. This is the normal contralateral side, and these are the right corticospinal tract deviated anterolaterally. The second question, where is the medial lemniscus? In fact, the medial lemniscus was here, just near and posterior to the deviated corticospinal tract. Another patient, and this patient can summarize the advanced neuro MRI package. There were a tumor which has been excised and radiated, and the patient came back 2 years ago with epilepsy and mild left hemiparesis. The area high up is hyperintense on T2, hypointense on T1, small focal enhancement, mild mass effect. So where are the tracts, whether this is a recurrence, whether this is an irradiation necrosis, what are the limits of the spread or infiltration. By tractography, the tracts are displaced anterior to the mass. They are crowded together. We can see here tracts crowded in comparison to the normal contralateral side. Crowded displaced tract on this area, while there are sparse, well spaced on the contralateral side. Performing spectroscopy, denoting that it is a recurrence, and not only a recurrence, it is of high grade. Interrogating the area around the tumor, preserved NAA anteriorly, denoting no anterior infiltration, preserved NAA laterally, denoting no lateral infiltration, while the NAA is depleted medially, denoting there is medial infiltration, as well as posteriorly. So that by this advanced package, we can get these data to the surgeon, that this mass is actually a recurrence, it is of high grade, this mass is anterior displacing the corticospinal tract and needs wide resection margin posteriorly as well as medially. Another patient, female, with a left thalamic mass, we can see that there is hyperintensity in the left thalamus, tumified, extending to the cerebral peduncle, hypointense on T1, with no enhancement, definite restriction. So this is an aggressive tumor. The surgeon wants to attack it, but what is the relation of that tumor to the corticospinal tract on that side? What is the relation with the optic radiation in that side? Performing the spectroscopy, we can see that it is of high grade with in the metabolite map that the choline is very high. It is hyperperfused. Aggression is suspected. This is the tractography. This is the corticospinal tract around the lateral margin of the mass. And if we couple this with the optic radiation, this is the corticospinal tract and this is the optic radiation. Both of them are intact. Both of them are stretched along the outer margin of the mass. On the coronal series, here is the corticospinal tract and here is the optic radiation. Both of them stretched along the outer margin of the mass. On the sagittal, this is the corticospinal tract, the mass, and here is the nicely demonstrated optic radiation reaching till the occipital cortex. Actually, the mass was attacked from the middle between both of them. Lastly, we reach the cervical tractography, which present a focus of a work in progress. We have tried this cervical tractography since about 1 year.